Dissemination meeting. We know that some people are on their way, but we have a very short window because we're working across time zones. So even though we're not all together assembled, we still want to make sure that we remain on time. It's a very interesting experiment that we're discussing. We have two sort of live spaces where discussions will be taking place. One is here in Jamaica, and the other is in Trinidad. And then we also have an online space for those who are joining us from other places or who are not able to be here physically. And so we'll see how we are able to blend virtual and face-to-face in a meaningful way. This is, I guess, one of our COVID experiments. It may be the last one that we're doing, but let's see how it goes. So welcome everyone. Thanks for taking the time to join us. I'm Marshall Toby, I'm Director of the Caribbean Institute for Health Research. I'm one of the investigators on the COVID-19 Metabolic Health study. This has been an interesting experience that we've had, and today is really giving us an opportunity to share some of the lessons that we've learned, and hopefully to allow us to have discussions that will allow us to utilize what we've learned in a meaningful way to transform, improve, enhance the care that we deliver to persons with non-communicable diseases, both in the Caribbean and to other parts of the world where the lessons that we have learned from this experience will be applicable. We have the first few minutes for greetings, and the first greeting that we're going to have is coming to us from the Executive Director of the Caribbean Public Health Agency, Dr. Joy St. John. So at this time we'll have Dr. Joy St. John's greetings at the beginning of the meeting.
Nurses during the pandemic. Good morning. It is a pleasure to speak to you this morning, but a deep regret that I cannot be there to participate. This is an important undertaking for many reasons. First, it is research conducted by Caribbean people about the Caribbean during one of the most disruptive periods of time, a pandemic and a public health emergency of international concern. Second, it is research about the non-communicable diseases situation in the Caribbean and how it was impacted by health sector reform of an unusual nature. This reform was imposed by a public health emergency, and the way in which that emergency affected severely under-resourced health systems in the Caribbean. I use the word severely because during the pandemic, the Caribbean did not get resources required to combat COVID-19 as freely as high-income countries elsewhere. PPE, lab supplies, testing equipment, and supplies specific to COVID-19, vaccines, treatments, and medicines were not freely available. And although the Caribbean was already plagued by shortages in human resources for health, high-income countries from other regions still recruited nurses during the pandemic. Thirdly, the sub-studies have potential to determine some clinical outcomes which can guide changes in operations and standard operating procedures. Fourthly, this process will bring evidence-based decision-making to the gold standard. On the heels of the declaration of the end to COVID-19 as a public health emergency of international concern, it is a good avenue to reflect on the lessons learned and to suggest recommendations for the management of future emergencies, particularly the management of NCDs in dire emergencies. NCDs have a significant social and economic impact on the overall health and well-being of Caribbean citizens. The time has come for Caribbean leaders in all sectors to stop treating NCDs management as only a health concern. Persons living with NCDs need effective policies to support them in remaining elements in the Caribbean's development agenda. While we have been developing strategies to combat NCDs, the COVID-19 pandemic has admittedly brought about many changes in the way NCDs are managed. What is needed is to re-strategize to include many of the changes that worked during the pandemic and not throw away these by the wayside. What is ultimately required is behavior change, and so policymakers need to walk the talk too. I wish you a productive meeting so that the outcomes will catalyze the change the Caribbean needs. I thank you.
All right, thanks, Dr. St. John, for your greetings. And the second set of greetings we're going to have are coming from the project sponsor, which was the UKRI, and these will be delivered by Dr. Hannah Boycott, who is the program manager with the Medical Research Council and has been our primary liaison over the last 2 to 3 years with this project. So this time we will have the greetings from Dr. Boycott.
Thanks, Marshall. So as Marshall just mentioned, I'm from the Medical Research Council in the UK. And at the start of the pandemic, we launched a call in collaboration with the National Institute of Health and Social Care Research here in the UK as well, which had the intention of funding impactful research into COVID-19. We were really excited to fund this particular project looking at the intersection of COVID-19 with NCDs, because it's such an important topic of research. And this study was extremely ambitious, comparing the 3 islands, and this was partially due to the unique position that the University of the West Indies occupies, and was a great strength of the project. So there have been challenges along the way with this research, as there have been with, I think, most projects that have been looking and working during this time of international crisis. But the team have worked extremely hard and delivered exciting research that's probably going to have far-reaching impact. We're really proud to have supported the team and happy to join today to celebrate their achievements. Thank you.
Thank you very much, Hannah. Thanks for those words. You've given us a lot of support even when things weren't going right. So it does give us some encouragement as researchers that we learn from our mistakes. All right, so at this time, we're going to sort of turn a little bit to some of the persons in the online and in the other spaces. Let me see, I don't know if Professor Simeon is ready but he can just maybe say one or two words of greeting and tell us who he has engaged so we can get a sense of who is in each of the sites.
Good morning. I trust that you can hear and see me, Professor Tollereid. Okay, I assume that you.
Yes.
I assume that you can.
Yes.
Okay. Right, because we have been having some problems with the audio in Trinidad here, but I'm hoping that everyone can hear me clearly. And for example, I'm not sure, but I assume that you would have, established the protocol and ensure that everybody who, should be recognized as present, you have done that already. So I say good morning to one of my colleagues here at the Hyatt in Port of Spain, as well as colleagues at the Pavilion in Kingston, and of course to you who are participating online. Just to know that one of the positives coming out of the COVID-19 pandemic was the level of collaboration among scientists internationally, with competitors working together for the greater good. This was, of course, reassuring as we were reminded of how much more progress we can achieve if we work together. This research project, of course, the impact of COVID-19 control measures and NCD risk factors in 3 Caribbean countries, comprise collaboration of researchers from 3 of the 5 UWI campuses. This is an excellent example of the one UWI in action, as well as a good practice for our health researchers who were able to pool our resources, expertise, experiences to address a priority issue. There were many challenges, as you will be hearing shortly, but we are pleased that the research had been successfully completed. On behalf of the Trinidad-based team, comprising Shelley-Ann Hunt, Marsha Ivy, Akil Williams, Akini James, and Candice Kendall-Mapp, we thank our partners at the Southwest Regional Health Authority, in particular, Ms. Michelle Marie Lafoucault, the General Manager, Policy Planning and Research, the staff at the Medical Records, and the lab at the San Fernando General Hospital. We are grateful as well to the doctors, nurses, medical record staff at the outpatient clinic at the hospital and at the Couva District Health Facility for their critical support. I must thank as well the data collection team and everyone else in Trinidad who contributed to the success of the data collection exercise. I also recognize persons who are present at this dissemination meeting from Trinidad, noting that many would have joined online. We have had some bad weather in Trinidad recently, and we actually have a severe weather alert right now. And I acknowledge colleagues from the Ministry of Health, the Southwest Regional Health Authority, the Faculties of Medical Sciences and Food and Agriculture, the St. Augustine campus of UWI, the Diabetes Association, Trinidad and Tobago Association of Nutritionists and Dietitians, TANDI, and the Chest and Heart Association of Trinidad and Tobago. I welcome my Trinidad and Tobago colleagues to today's meeting. Of course, a research study does not end until the findings are disseminated. Importantly, the findings must be shared with all of those who took part in the process, as well as those who can benefit from what was found. I end my remarks by sharing that I was recently invited to review a guide titled Expanding the Use of Your Research, the World Health Organization Guide on Research Communication for Policy. Notably, it identified the dissemination of research findings as a component of research communication. The key elements of good research communication include the findings being accessible, actionable, credible and trusted, relevant and relatable, timely and understandable. Researchers are encouraged to be creative and inclusive in communicating their findings. This is the approach that will be taken with this project, starting with today's meeting. And of course, we look forward to the input of all our stakeholders. Thank you, of Tolori.
Thank you very much, Professor Simeon. Professor Simeon, of course, is director of the Caribbean Center for Health Systems Research and Development, a unit that's based at the St. Augustine campus at UWI. Yes, very well said. Thanks for making everyone feel welcome and for engaging us and reminding us of the purpose of this meeting. So at this point, I'm going to hand over to Professor Simon Anderson. He's director of the Georgia Lean Chronic Disease Research Center of CAIHR. Professor Anderson.
Thank you, Professor Tollereid, and greetings and good day to all participants online and in person. Actually, this is a quite interesting start for the dissemination because the project was done online and in person. I hope you can hear me.
Yes, we're hearing you fine.
Okay, perfect. So all protocol has been observed. I want to, first of all, thank our funder, because without the gesture from the MRC and the UKRI, we would not have this project. It came at an opportune time and allowed us to contribute to the knowledge related to the intersection between NCDs, infectious disease, and the impact that it had, particularly in populations of Caribbean origin. We were able to undertake our project despite the challenges that we faced, and we are successful because of the hard work of some contributing teams and persons. I think the key person to thank, of course, the Ministry of Health and Wellness and the CMO, Dr. Kenneth George, the Honorable Dr. Kenneth George now, and his team, including Dr. Arthur Phillips, who allowed us the space to utilize the Queensbrook Hospital, and then DMS, the Director of Medical Services, Dr. Clive Cade, and current acting DMS, Dr. Cheney Williams, including colleagues in the department diabetes and endocrinology, that allowed us to gain access to patients and information related to that we required to undertake the study. So that includes Dr. Mike Crimsholes and his team, which includes Amanda Bodenarine and also other colleagues. I'm also grateful to our research nurse, Mrs. Martinet Ford, who then took the bull by the horn and ensured that we kept our numbers going despite whatever was happening. And also, we should mention Miss Eden Augustus, who worked tirelessly creating databases, solving problems that we've had in relation to the study to get things going. So it is a coalition of the willing that activated the study and completed it, and I'm pleased that at this point in time we're able to share it with our community. Thank you very much from the GACDRC.
Thank you very much, Professor Anderson. Okay, and that's on behalf of Barbados. So after hearing those two erudite professors, I'm wondering what I'm doing here. I have to try and make everyone feel as welcome as they did. I'm not as organized in terms of my remarks, but I will also add my share of welcome to those who are physically here with us, and also to those who have joined us online as well, because we know not everyone could be here. This was really indeed a learning experience for us, because there are a lot of things that we had to learn to do differently during the period. And as has been attested earlier, there's been a lot of hard work, ingenuity, and creativity, which has gone into what we're able to share with you today. We've adjusted a lot of the methods that we typically use, and we've had to work around a number of the challenges which we encountered in things that we had anticipated would have gone more smoothly. I also have to add my share of thanks to the 2 hospital settings in Jamaica which facilitated our work, the University Hospital of the West Indies and the Mandeville Regional Hospital. both the leadership and staff of institutions were very facilitatory in allowing us to get the information that we needed and allow us to reach this point in the project. Of course, the staff, many of whom are here today, employed primarily to the project, or other persons who are part of the department or the University of the West Indies in other ways, have been very instrumental in getting us to this point. And I think I just want to kind of give people a sense of who is here. And I think so far I'm seeing representatives from academia, from the University of the West Indies, including our Director of Graduate Studies and Research, Professor Lee. I see a number of persons from the Ministry of Health here as well, in various capacities of leadership. I see Dr. Spence, Dr. Williams, and in other areas that have contributed and are important in shaping the policies that we're going to put forward. So with those opening words of welcome, I hope we can proceed now with the first activity of the day, which is just kind of talking about my experience. All right, so I'm being monitored because we're trying to keep on time. So we'll start with the first set of slides. Is really just talking about what happened. It's interesting because in putting the slides together, I kind of felt a little bit strange. I think a bit of post-traumatic stress disorder when I remember what I was going through when this was happening. But I think so all of us will have a little bit of that deja vu. But the idea is that we should be paralyzed by it, but it should help us to think about things as we move forward. So if you can proceed to the next slide. So we're going to be talking today about this study. This is the official name that we put on our application. We call it the COVID-19 Metabolic Health Study for short. And a list of all the investigators is on the slide. Many of them were there from the very beginning, and then others joined, especially as we moved on to the other half of the study, where we did some more of the qualitative and other sub-studies. So the next slide. Of course, this is a collaboration, as was mentioned, between several of the campuses of the University of the West Indies. The University of the West Indies does have one of the, is a regional university. So because of that, it allows us to reach across sites. And so that was one of the things that facilitated our thinking around a multi-island collection of data. And this project was sponsored by the UKRI through their Medical Research Council. So today I'm just going to talk a little bit about what we were thinking about when we started designing the study, and then a little about what are some of the things that we had to do differently in order to execute what we are presenting today. So we know that for the Caribbean, there's a high burden of non-communicable diseases. In fact, when they look at several of the surveys that have been conducted in the region, we're looking at things like diabetes. About 10 to 20% of the population has diabetes, and hypertension prevalence is even higher. Up to 50% of the population in some settings has elevated blood pressure. And data from the region has shown that non-communicable diseases for the Caribbean are the leading cause of death. And in fact, when it comes to the Americas, the Caribbean is the region of the Americas with the highest premature mortality from these non-communicable diseases. So they definitely have a very big impact on our lives and also our economy. Management of non-communicable diseases is not a simple thing, because these are conditions that people live with and have to function with all the time. And there are a number of things that will make somebody successful when it comes to whether or not they're able to control and manage their disease in the best way. So they have to have the ability to make healthy food choices, to be physically active on a consistent basis, to get adequate rest, to have access to and take their medications as prescribed, and also having the right attitude to maintain a number of the habits which are critical to the control of the disease. They should also be able to see their healthcare providers on a regular basis so that adjustments and important diagnostic tests can be performed. So here we have a situation with a country with a high burden of non-communicable diseases, and then comes an infectious disease, a pandemic, which took the world by storm. We had our first cases of COVID in March of 2020, and of course, all of the region was put on curfew. I don't know what to call it. we went into a bit of a state because everything that we had in terms of knew about our regular day-to-day lives was completely adjusted. So to prevent the spread of this condition, for which we had no good understanding of its treatment, we saw what was happening in Italy, where hospitals were overwhelmed, in the US, where hospitals were overwhelmed, where ambulances were moving people from the morgue, from their home, all day and all night, to a situation where this is coming to the region. We know that the facilities for the region cannot accommodate that kind of intensive care and treatment. We're understaffed, we don't have the resources, we don't know how to treat this medication. There's no vaccine available at the time, and there's no good treatment available. How do we keep it from spreading? And so the idea of managing COVID-19 in the region was one of reducing our exposure to the virus, which meant cutting off a number of the normal means of communication, so closing of borders, restricting movement, all in an effort to try and sort of broaden the curve. So in other words, rather than have this peak where everybody will be exposed, we're trying to flatten the curve so that we can have maybe manageable amounts of the disease and not be overwhelmed by it. And of course, a number of things were put in place. So in addition to the normal closures, which were taking place generally, closing of borders, shutting down of schools, reducing people's working, encouraging them to work from home, closing down restaurants and a number of places where people normally would congregate and where there would be a risk of spread. There were some specific measures which were taken in each of the islands that we looked at, which we thought were quite interesting. So the study actually came about because somebody called me and said, did you know that in Trinidad they've closed fast food restaurants because of COVID-19? So it's not just closing indoor dining, which is what we had in Jamaica, but there's no fast food restaurant that's available for you to get your chicken and other things that you're used to. So what's going to happen there? And it was a sort of interesting natural experiment because, you know, for a lot of us who are public health advocates, this is something that we may want to to go championing. Anyway, we're too close to the newest chain to make too many comments. But it was really one of the things that a lot of people have been saying, well, what would happen if people didn't have access to some of these things which we consider unhealthy? But we know that this wasn't the only place that they're not having access to. They were now not necessarily having access to some of the other places where they would get food. They were not able to have access to some places for recreation. And then even movement to obtain care was also impacted. So looking at the situation, there could be positive as well as negative effects from a lot of the control measures. And this is really one of the things that we wanted to explore in this study. So because COVID was in place and there were a lot of restrictions in movement, how could we actually conduct a study without actually using the methods that we're used to? So a lot of times when we are engaging persons for research, we will approach them in a face-to-face manner. We will go to see them in the clinic, in the hospital, in the community. Our interviewers will go out. We'll tell them about the study. We can establish that rapport. We are able to go into spaces normally and freely to the hospital or other places where we think that our sample could come from. We're able to do our interviews and then collect the data. But here we have a situation where we're not able to actually approach people. How do we find persons that we want to talk to? And so the decision was taken to go through an electronic sort of platform or sampling approach. And the best sort of place that we thought we would find persons who would be eligible for the study was looking at people who are having lab studies done. And the two lab studies we're interested in were glucose and cholesterol panels. So these are commonly ordered for persons with diabetes, hypertension, heart disease, and many other chronic illnesses. And so if we're able to go into a system that could identify people who are having these done regularly, we might be more likely to identify persons who were suffering from, or I shouldn't say suffering, were living with non-communicable diseases and could therefore be eligible for our study. The laboratory information systems we felt would be most robust in the hospital. because of the technologies that are there, and also it's a little bit more finite. So we could go into a laboratory information system for a clinic, but then that would be covering maybe not just people attending that clinic, but people from other places, and so on. So the hospital was a place that we thought we'd go. We identified 4 hospitals, 2 in Jamaica, 1 urban, 1 rural, and 1 in Barbados and Trinidad. The idea was to go through the lab information systems, identify people who had these laboratory tests done, and then contact them using the hospital records department, because they would have information on the person's contact information. Because we couldn't have people meeting face-to-face, these interviews were to be done by telephone, which was a new experience for us. And then we wanted to look not just at the responses to the questions, but also to track the impact that these measures were having on health. And so this would include tracking of the laboratory data that was collected from these participants over time, as well as pulling information from the records, such as the weight and blood pressure, which would also give us an indication of what was happening to people during the pandemic. So that was what we had planned. It looked very good on paper. And then when we were ready to do it, we realized that we had to, as Professor Jackson would say, well, wheel and come again with indecent haste. So let's go on to some of the challenges and adaptations that we had to make. So one of the first things that we recognized was that there were some challenges in terms of how we were able to collect data. And this was because hospitals were very focused on the pandemic. There was a lot of closure of normal systems, so even the outpatient clinics, staffing was kept to a minimum. Everyone who was there was under a lot of stress, and they weren't necessarily entertaining outsiders coming into a space which was kind of already tense and could potentially increase the risk of spread. So that was one of the challenges that we had in terms of getting into the space. We also had challenges with ethics approval because a lot of the facilities, at least one of them that we had initially targeted, was concerned about bringing additional staff in and even conducting research during this period because of risk and also shortage of staff, as everybody was now deployed and focused on the COVID-19 pandemic. This was something that was going to have to be done virtually, so it was a lot of work by Zoom. We did know the persons beforehand, but still, you know, there's nothing like a face-to-face meeting where you can kind of think through some of the ideas and get a little more progress in terms of going on to what you want to achieve. We had to figure out how to train our staff. So train them to do this kind of methodology remotely instead of face-to-face. So everything was being done on Zoom. Figure out new ways in which we could collect the data and communicate with each other. So if we wanted to know, okay, did you contact this person? How do we know that these people have been contacted? How do we know when the interviews have been done? How do we know when we should be ready to distribute incentives to persons who have completed things? How can we tell when they've gone back for laboratory studies? And so even this ability to collect data, not just in a single setting, but also to collect it in a way that these data would be available for somebody who is working on the project from Barbados, as well as Trinidad and Jamaica, to understand what is happening in each of the settings. And then, of course, in addition to that, one of the big challenges that we had was how we could establish relationships with participants. So these are some pictures which I thought were really very indicative of what was going on. So a lot of the research assistants, when they started, looked like the lady on the in the top corner. And by the end of 2 weeks, they were looking like the gentleman. When the phones were cut off and you call them back and nobody answers. Or, you know, this is a little longer than we thought. So let's bring this to an end. And I think this was really, that article that you see there is really a blog, and it was actually one of the key things, that one about I just called to say I want to interview you. I think it's a very good read for anybody who's going to try and do telephone or remote data access in terms of some of the experiences that people will have establishing the rapport and establishing trust with participants. We had a number of challenges as well with our laboratory information systems. A lot of them, the settings, they don't have dedicated information technology staff. And so even though you're able to utilize the system on a day-to-day basis for collecting data, providing reports, etc., there were challenges pulling data in a way that we could merge it with other samples that we had. The fact that many patients have multiple ID numbers also made it difficult, because you have similar names, but then if you're trying to match on names and you're seeing different numbers, is it two different people with the same name, or is it really the same person who has been given another registration number, maybe because they came in as an emergency or something was happening? The contact information was another challenge. So even when we were able to identify persons who met the criteria based on the lab tests that were being done, the contact information, we know, for instance, for Jamaica, that numbers come and numbers go. So the one I called you on last week may not be the one that works this week, or the phone is shared by a number of people. And so when you're trying to make contact with them, it's a little bit more challenging. And of course, remember, we're doing this at a time when movement to go to people's addresses and other places really was restricted. And so eventually, as the COVID-19 pandemic came to an end, we realized that if we were actually trying to execute this project in a meaningful way, we had to use a blended approach. And so we're able to now begin to go into the outpatient clinics, make contact with persons, which made a big difference in terms of establishing that rapport, and then completing other aspects of the study remotely, which would reduce the risk of infection and other problems. So this is really the last slide, which talks a little bit about our sample. We had initially planned to have about twice as many people enrolled in the study as we had. I think we've learned to be satisfied with what we got. In all, about 661 persons across 3 sites were enrolled. For Jamaica, we enrolled from 2 sites. Jamaica, the sample from Jamaica was a little younger than from the other sites. We also had the largest number of men in the sample coming from Trinidad. Jamaica had a higher proportion of persons with primary education, and also the number of people on government assistance was about the same across all the sites. Regardless of where we went, most people had multimorbidity. And what we talk about with multimorbidity, meaning that they're living with 2 or more non-communicable diseases. Nearly 80% of the sample at all 3 sites had 2 or more diseases. And then the rates of self-reported COVID-19 infection were lowest for Jamaica. But some of these effects we have to think about in terms of the time during which the data were collected. So with those few introductory remarks, I can bring my section to an end. I don't know if there are any burning questions before we start going into some of the results from the study. And remember that for those who are online, you can type in your questions. We can take those. For those in person, if there are any special comments or thoughts, you can also share those with us as well. Okay? All right. Okay, so remember, there will be time for question and answer later. So you can keep those in mind. So our first set of results, so we're going to present the results in theme areas. We're going to talk a little bit about food issues, other lifestyle issues, health system aspects, and also a little bit more about the experiences that persons had in different fora. So the first presentation is going to be done by Ms. Joette Mackenzie, who is one of the project investigators and a research assistant here at the Caribbean Institute for Health Research in Jamaica. She's a nutritionist, and also has been doing a lot of logistics for studies. She was one of those who was very instrumental in the early phases of the project in the design. I'm going to invite her now to fill in for Ms. Eden Augustus to talk a little bit about diet and food insecurity, or findings from this survey.
Thank you, Professor Tola Reid, and good morning, everyone. Thank you for joining us today. So as Prof mentioned, we're going to be talking a little bit about the dietary patterns that came out in our study. So we use a culturally adapted food frequency questionnaire, and we measured the intake of our participants over the first 3 months of the pandemic. So from March 2020 to May 2020. And then we also asked our participants how their consumption of different food groups changed with the pandemic. Coming out of our principal component analysis, we were able to identify 3 patterns of our dietary pattern, So first off, it was the healthy dietary pattern, which consisted of fruits, vegetables, legumes, nuts, and seafood. And then our second dietary pattern consisted of processed meats, rice and pasta, low vegetable consumption, and low soy intake as well. And then our third dietary pattern consisted what we call our traditional dietary pattern consisted of avocados, poultry, fruits and vegetables. This is root tubers and starchy fruits, that is, for our third dietary pattern. And so when we were looking at the associations, we found that the healthy and the fast food dietary patterns were not associated with any of the socio-demographic characteristics or the number of cardiometabolic disorders. But what we did find was that the traditional dietary pattern was more common among the younger persons as well as those with tertiary education. So moving from the dietary patterns, we looked at the food changes over the course of the pandemic, and we found that when we took into consideration those healthy food changes, we saw that water consumption actually increased, where 65.6% of our participants actually reported having increased water consumption versus 4.6% actually said that they had decreased water consumption, and 30% said it remained the same. When we looked at our vegetable consumption, 37.4% of our participants said that they actually increased their vegetable consumption over the course of the pandemic versus the 18.4% that said that, they decreased consumption. 44.2% said that they had no change in vegetable consumption. When we went down to our peas and beans, 23.1% of our sample said that they actually increased their consumption of peas and beans, whereas 12.7% said that they decreased it, and then 64.2% said that it stayed the same. And then for our final healthy food change, we saw that 36.6% of our participants said that they increased their food consumption versus 20.8% said that they decreased it, and 42.6% said that it remained the same. So that takes care of our healthy food changes. When we looked at our unhealthy food changes, and that takes in fast food, meat, sweetened beverages, and alcohol, 5.6% actually said that they increased their fast food consumption, whereas 40.6% said that they decreased their fast food consumption, and 53.8% said that it didn't change. Whereas for our meat consumption, 13.9% said that they actually increased over the course of the pandemic versus the 28.7% that decreased meat consumption. And of course, 57.4% said that it remained the same. Going down to sweetened beverages, and sweetened beverages and alcohol, you can notice, actually has the same percentage. 10.6% of our participants said that they actually increased both sweetened beverage and alcohol consumption. But for the sweetened beverage, you'll notice that 32.7% actually decreased their sweetened beverage consumption, whereas 56.7% said that they remained the same. And then for alcohol, 20.6% said that they decreased their alcohol consumption versus 68.7% said that it remained the same. And so when we look at food insecurity, we actually measured food insecurity using the Hunger Vital Signs, which is a validated two-question food insecurity screening tool based on the US Household Food Security Survey module. And we use it to identify the households at risk for food insecurity. When we compared across country, both the pre and the post-COVID food insecurity, and of course this was adjusted for both age and sex, we found that 55% of the participants in Trinidad actually reported being food insecure versus it jumping up to 71.2% during the pandemic reported being or having been classified as having food insecurity. For Jamaica and Barbados, you'll see that the reverse is true, where Jamaica actually had 70% reporting food insecurity before COVID-19, and then during it dropped down to 65%. And Barbados started off at 66.5, and during the pandemic went down to 51.1%. So when we looked at the characteristics of those persons that reported being food insecure, we found that more persons were women. They actually had a lower educational attainment. They were of rural geography, and they were about 18 to 44 years old. And that will take care of the dietary patterns that we explored for this study, and now I will hand back over to Prof. Reid. Thank you.
Okay, so we have a few minutes for questions and answers in case anybody had any reactions to the data that they saw, if there's anything that they are kind of not so sure about or surprised by or not at all surprised by based on the data that was presented. Professor Henry Lee. Okay, the mic is
yes. Good morning, everyone. Aldry Henry Lee, UWI. I was just saying to my colleague that in other studies, we saw an increase in food insecurity among the population during COVID, but I realized that you have a specialized target group, so maybe they were a little more aware of the health needs in Jamaica. So I just wanted you to elaborate a little about that, because I know that the other studies that we have examined show an increase in food insecurity in Jamaica. Thanks.
Right. So thanks for that question. So even though the numbers may appear to be a little bit different, when we did our statistical testing, there didn't seem to be any difference, significant differences between the prevalence or proportion of people with food insecurity before or after the pandemic. I think for us, what is a little surprising was a high proportion of persons who were reporting that there was food insecurity. So nearly 70% of these persons living with non-communicable diseases. Part of it may be the issue of how we assessed it. So the two questions we asked were really around whether they had access to healthy foods. And of course, the options that they were given was like always, sometimes, never. Once somebody could not say always, then they were being classified as food insecure. And so that may have been one of the reasons why the prevalence appears to be quite high, because once you can't say that you're certain about whether you can get healthy foods or have access to the foods that you need to control your diseases, you'd automatically be put into that category. So it may be partly around the definition, but this is really what we utilize. And I think that was a key finding in terms of what was happening during the pandemic. But necessarily, it didn't seem as though the pandemic had a big impact. And that some of these things were explored a little bit more in our qualitative exploration, because we actually went back and tried to speak to a number of the persons who were giving responses around food insecurity to understand what their experiences were, what it is that they were looking for when they were talking about healthy foods, and then what challenges they had accessing these during the pandemic or even before the pandemic. And I don't know if there are any questions online, so that's also another option. We want to make sure that those who are online can also engage, or in any of the other sites if there are. I think one of the things that we were looking at as well was the patterns, because we were interested in seeing how the patterns would change. And I think a couple of things I think are positive. One of them was most people reporting increased water consumption. And I'm not sure if that's because they weren't able to go out and get some of the other beverages and had to pick from what was at home. So that was a good thing. But in speaking with other researchers, there may be also something specific around water. So the idea of water flushing the system. And so the need to have a lot of water to get this virus out if you're exposed to it. So that may have been one of the drivers. I think one of the other good things is that we didn't see a very big increase in sweetened beverage consumption, which was also good. I don't know, again, if that is because of restrictions in terms of where people would normally access some of these things, if they get it at work, or, well, this is adults primarily, or when you go on the road, because we know what is usually served in the clinics when patients are waiting to see the doctors. So they may have had a few less drinks because they weren't able to go as often as they could. So I think those were some positives. We did see some differences in the consumption. So we haven't really presented some of the country-specific data in this. But one of the things that I had found quite interesting was where we would have expected a reduction in some things like access to fruits or vegetables in places where food is primarily imported. We actually did see the biggest reduction in those foods in Jamaica. And we had expected to see a smaller reduction in persons who are living in rural areas. We actually saw the biggest reduction in consumption of fresh foods in people who are residing in rural areas. So again, it kind of raised for us a number of issues around how people access. So we assume that somebody who's in a rural area will have better access to fresh foods and vegetables. But there's a little bit more about the food dynamic that we don't understand, because whatever was happening at the time of the pandemic was inhibiting their access. And then when we were doing some exploration, we normally say, oh, somebody who's living out of town will be farming and have land and so on. That's not necessarily true for a number of patients with NCDs. So that's something that we have to bear in mind. Professor Jackson. The mic is coming.
We were having a little bit of crosstalk on this table here with respect to the dietary pattern. We were having a bit of crosstalk here about the dietary patterns. Why is it that we were seeing in the traditional that higher educated younger persons were more likely to consume the traditional? And intuitively you think traditional, that has got to be older people. Well, I'm suggesting it may be a function of self-monitoring. The higher educated younger is more likely to do better self-monitoring. If you look at how the foods loaded, you had avocado, fruits and vegetables, starchy fruits, roots and tubers. We know avocado, for example, has lipid-lowering properties, where it will lower low-density lipoproteins and triglyceride while increasing HDLs. We also know it has phytochemical properties. Your fruits, starchy fruits, roots and tubers, what do we think of? Fiber. What is the effect of fiber on lipids and glucose? It has lowering. Plus the antioxidant properties, which is anti-inflammatory. Yes?
Okay. Okay. Oh, you want to the mic. Go ahead, Dr. Hilton Kong.
Morning, thank you. I had to step out, but I thought I saw included in the traditional was chicken.
Chicken, okay.
And so I was questioning that because like traditional, that's like everybody's meal in all of the Caribbean with two fly. But, so I was wondering how it would skew that, those responses. I'm not sure if they responded according to the different traditional foods and so you could separate it. So I was wondering about that.
Okay, so Professor Jackson is going to respond. Oh, we're coming with the mic, Prof. Jackson.
It's white meat. Chicken is white meat, not your red, which you're going to be having more of your saturated fats.
I think the other thing that that sort of came out a little bit through some of the qualitative work is the point that you're making about self-monitoring and the ability to do some of the things which are definitive in terms of improving care. So a lot of older persons, for instance, because of the stay-at-home order in Jamaica, would not have been able to go out. So even when you're thinking about, okay, how can you continue to have a traditional diet in the setting of the pandemic, if you are not able to go to the market? So a younger person could probably go to the market more often. A more educated person could get to a particular chain store before it closed. So that may have been one of the factors that, or go order online. Yes, Dr. Kong, you are doing that. And let them deliver it to your house. And so they may have been able to continue to have a more traditional diet, whereas you find that maybe some of the older persons may not have had that access. And so you find that that's a little different. I mean, I think the other thing that we were kind of surprised about was that we thought the fast food pattern didn't vary by social status. So there weren't any sort of relationships that we were able to pick up just with demographics. We always say the younger people have been the ones trying to get the chicken, the fried chicken, etc. But that didn't seem to be the case. So I guess there's more as we begin to explore these patterns and even the impact that these patterns had on metabolic health during the pandemic. Okay. All right. So I think we have to close this section. Oh, okay. All right, we can take one question or close. We're going to, okay, we have to move to the second segment. So we can take your question as well a little later on. So we're going to move on now to the second group of presentations, which is really talking about the other lifestyle factors. So please hold your question because we can probably bring it into the question and answer for this section. And then Mr. Keel Williams, one of the project investigators who's currently based at the Caribbean Public Health Agency in Trinidad, is going to talk a little bit about our findings as it related to physical activity, sleep, and mental health during the pandemic.
Hi, good morning, everyone. All right, so as Prof. Talariuda mentioned, I will be going over the lifestyle patterns such as physical activity and sleep and looking at mental health of the participants. So we're going to first look at the physical activity. So when we conducted this study, we asked participants 2 questions, and those questions were to collect data on leisure time physical activity as well as perceptions of physical activity changes during and before the pandemic. So during the pandemic period that we were looking at was March to May 2020. Next slide, please. So looking at self-reported leisure time physical activity, we asked persons how many times on weekdays and weekends, how many minutes, per day on weekends and weekdays that they spend being physically active, and that could have included walking, jogging, swimming, and gardening, and other activities as well. And we noticed that before the pandemic, that 97.7% of the persons had reported that they had less than 150 minutes of physical activity per week, and 2.3% of those persons had greater than or equal to 150 minutes per week of physical activities. Now, during the pandemic, we saw that, again, 97.9% of persons, so the majority of persons did state that they had less than 150 minutes per week of physical activity, whilst 2.1% of the individuals said that they had greater than or equal to 150 minutes per week of physical activity. So we could see that both before the pandemic and during the period that we were looking at, that most of the population were physically, they had lower physical activity. So we can move to the next slide. So after that, we looked at perceptions of physical activity. And the question we asked participants were, have you noticed that your physical activity has changed compared to before the COVID-19 outbreak? So here we can see that the 12.6% of persons said that their physical activity had increased. 38.5% of the individuals stated that their physical activity decreased. 38.2% of the individuals noted that their physical activity stayed the same, and about 10.6% of the persons said that they weren't sure if their physical activity had either increased or decreased, or if it stayed the same. So we see that the majority of the persons if you just go back a little bit, sorry. The majority of the persons who would have presented, who had reported, stated that their physical activity would have decreased during the, if they compare pre-pandemic to during the pandemic. So moving on, we're going to look at mental health, and mental health in this instance would be depression and anxiety. So we use the hospital anxiety and depression scale, so the HAD scale, to assess participants' current feelings at the time of the interview. So just to note that this, at different sites, we would have collected data at different periods. So that may also influence some of the results that we're seeing here. So the HADS questionnaire, it scores from 14 questions, 7 on depression and 7 on anxiety, and they were classified into 3 groups, or 3 categories. So for depression status, we saw that 79.5% of the persons had, they were normal, 12.8% were borderline abnormal, and then 7.7% of the persons were abnormal or considered to have depressive symptoms at the time of the interview, right? And the majority of our sample, had normal, they were normal for depression or did not have depression at that point in time. And we could also note that there was, when we conducted our CAIHR test for association, we saw that there were statistically significant associations between age and country for depression. So we now move on to anxiety. We see that the majority of the population, 76.6% of the persons did not have any anxiety-related symptoms. 12.3% were borderline abnormal, and finally 11.1% of persons had anxiety symptoms or anxious at the period of the interview. So we see that the majority of persons had no symptoms of anxiety, and when conducted our chi-square tests of association, we saw that there were statistically significant associations for sociodemographic characteristics such as age, country, education, and occupation. So we're going to move on to the final part of the lifestyle practice, patterns, so sleep status. So we would have asked persons questions, one question actually on how many hours of sleep that they would have had within a 24-hour period. And based off of the responses of that, we would have categorized them, and we would have used that the 7 to 9 hours of sleep as the recommended for adults. Next, yes. So before the pandemic, we saw that 42.5% of the persons had less than 7 hours of sleep. 51.1% of them had 7 to 9 hours of sleep, and 6.4% obtained greater than or equal to 10 hours of sleep. And during the pandemic, we saw that persons, 42.8% of individuals had less than 7 hours of sleep. 50.2% of individuals had 7 to 9 hours of sleep, and finally 7% noted that they obtained greater than or equal to 10 hours of sleep. And we can see that both pre and during the pandemic, for the period that we were looking at, that most of the participants, about 50% of the participants had gotten the recommended hours of sleep. And when we also conducted our chi-square test of association, we do note that there were no statistically significant association with the sociodemographic characteristics that we looked at, and this could be for age, education, occupation as well. I'm not not sure, well, yes, if anyone has any questions regarding this particular section.
All right, so we have a few minutes for questions before we move on. Okay, everybody wants to leave the questions. I'll just take no burning questions. Everybody's happy. I'll just want to make sure while the moment is hot. We'll have time for questions as well at the end. Professor Ferguson, just one question.
Okay.
And this is for Mr. Williams. Your exam starts again now.
So thanks very much, Akil. Very good presentation as per usual. I just wanted to find out about the question items that were used in assessing the physical activity that we had just, well, almost 97% of persons with chronic diseases not meeting the 150 recommendation, to me, is alarming. So the question is, how did we measure this, and how confident are we that we're capturing all leisure time physical activity?
Thank you for the question, Prof. Ferguson. So when we, the question that we would have used, we'd ask persons how many minutes that they would have spent conducting the leisure time physical activity. So they would have recorded the time that they would have assumed that they would have conducted that those physical activities. So we use that, and we collect information on minutes and days as well, and we would have calculated that we'd have created a total, for the physical activity that they would have done for the entire week, and then we classified it using WHO recommendations. I know currently these are just preliminary findings, so I know as we continue to explore the data moving forward, we'll be able to assess how confident we are in the findings based off of the amount of persons that would have had, the 70% of persons that would have had NCDs from the population that we were looking at.
Yes, and I'll just add to that. I mean, we did ask about deliberate, and we're not looking at all physical activity because the telephone interview, there's a limit to how, intensely you can probe without people hanging up the phone on you. But this was really about leisure activity. So we know that people with chronic diseases are encouraged to have 30 minutes of moderate to physical activity per week. And the questionnaire did ask about weekday and weekend activities, so we captured both. And really what it shows is that the majority of persons that we interviewed were not involved in any form of physical activity, and restrictions of the pandemic did not make a difference to them. We have other questions which we didn't present, like whether there are members of gyms. That was very low, right, Akil? Very few people were involved in sporting and other activities. So even the restrictions that were put in place didn't seem to impact that aspect of life to a great degree. All right. And then we saw sleep seemed to be good, and then Akil made a point about the anxiety and depressive symptoms during the pandemic. So I get the impression that we're being encouraged to move on. So again, there'll be time for question and answers when we've finished all of the main presentations. But at this point, I'm going to hand over to Ms. Kerry and Facey, who has been doing a lot of coordinating and other work for the project. She's one of our research assistants at the Caribbean Institute for Health Research, and a recently awarded epidemiologist. So she will be presenting some of the data that was done by Akini James at the Caribbean Center for Health Systems Development in Trinidad on healthcare experiences by patients.
Good morning, everyone. Another area that we looked at in our study was patients' healthcare experiences during the COVID-19 pandemic. And it's important to understand the setting where we collected our data. For Trinidad and Barbados, we collected our data at urban hospital settings, and for Jamaica, we had 2 hospital sites, one rural and one urban. And these hospital sites are slightly different as the rural is government operated, so there is no fee at point of service. But for the urban site, it's more semi-private and patients do have to pay a fee for service. We grouped patient experiences into 4 categories, which we will now discuss. For patient decisions, we're looking at patients changing their appointments or they're rearranging their schedules during the COVID-19 pandemic. And we see that persons in Barbados and Trinidad were more likely to reschedule their appointment because of fear of COVID-19 safety at their usual healthcare facility. And also a quarter of patients reported not going to the clinic because of overall COVID-19 safety concerns at their hospital. We also looked at appointments, and patients from Barbados and Trinidad were more likely to report their appointments being canceled. We saw that about a third of patients reported not seeing their doctor after turning up for their appointment, and over 10% of patients had difficulty in rescheduling a follow-up appointment at their clinic. For emergency cases, we see where persons in Barbados were less likely to report having to go to the emergency room for management of one of their conditions, chronic conditions during the pandemic. And then we see in Jamaica, patients were more likely to report being hospitalized because of a health problem, and also they were more likely to have difficulty in terms of finding another facility to write up their usual prescription if it is that they weren't able to get the prescription done at their usual healthcare facility. For medication, we see where Barbados and Bajan and Trinidadian patients were more likely to report having issues in terms of getting their usual medications from their pharmacy. Jamaican patients were more likely to report seeing an increase in the cost of their usual prescriptions, and over a quarter of patients ran out of their medications between their doctor's appointments. In Barbados, more patients were more likely to have to stretch their medication in between doctor's visits. Thank you. I hand over to Prof. Reed.
So I don't know if there are any immediate reactions or questions anybody has for Kerry. Things are being handed over about the results or the findings from patient experiences. Everybody seems to be, I think that sounds typical. Does it sound? All right, so I guess everybody agrees that this is really typical. I think one of the things we spoke about was the need for access to care and care facilities. We saw where patients had fears about their own health, especially with the messages they got about non-communicable diseases during the pandemic, and those conditions would be considered at high risk. So exposing themselves unnecessarily was something that would be in the back of their minds. But then even the ability to make contact, I did notice the differences that were there between some of the sites, and I'm not sure if even the ability to have appointments canceled and rescheduled may have been in part because of differences in data systems. So I know that sometimes it's challenging contacting patients. I see some people here from medical records. I don't know if they had any challenges contacting people to say, okay, no appointment, or come back next week. Yes. Oh, there's one comment, if we have the microphone.
Thank you. I'm just wondering about so that was during the COVID. Mm-hmm. Did you do a comparison outside of COVID?
we didn't do a pre-COVID.
Because some of those numbers I've seen are regular.
Okay. All right, so they may not be attributable to COVID because that's what this is the normal. Okay. All right, so the important point. All right, so just to kind of round off our presentations, and I don't see, oh, Dr. Bailey, okay, she's online. Okay, good. All right, so we have Dr. Bailey online, and one of the elements that we were not able, but we are sharing as well, is that we actually did some qualitative work. And so we have Dr. Althea Bailey, who is a senior lecturer in the Department of Community Health and Psychiatry. We had conscripted her to help us with the qualitative aspects of the study and to understand a little bit more about what was happening during the pandemic and to understand maybe some of the figures that we're seeing. And she's going to share with us some of her preliminary findings from the qualitative interviews that were completed. So Dr. Bailey, we hand over to you. So this remote working isn't working. Dr. Bailey is coming online. But I think one of the things that we had, when we started doing our preliminary look at the data, and even from our interactions that we had with members of the health team in executing the study, because we had to actually do a lot of face-to-face visits, was that there were a lot of experiences that persons were having. A lot of initiatives were taken by the health system to accommodate patients in the setting of the pandemic. And a number of patients had different experiences, and even from the responses, we wanted to understand the reasons behind choices and decisions that were made. And so the additional funds that we had allowed us to do some qualitative exploration, and Dr. Bailey has been involved in a number of the discussions with patients and providers, and she's going to share a few of the preliminary findings in her qualitative report. So Dr. Bailey, again, Senior Lecturer, Department of Community Health and Psychiatry.
Okay, good morning, everyone. I hope you're hearing me well. I am going to present, as Marshall said, the qualitative findings for the study. All right, so first of all, to just explain that there were basically two sets of qualitative data collection. One was among patients who we were looking at food insecurity, and we looked at male and females using patients from University Hospital of the West Indies and Mandeville Regional Hospital. And of course, we also looked at the staff, the medical staff, including non-medical, I should say the health staff, including non-medical and medical. So we had administrative, drivers, and then we had nurses and doctors. And of course, the administrative would include the clinical administrative. So we had a CEO from both hospitals. Next slide, please. All right, in terms of the findings, food insecurity, the instrument asked about knowledge of healthy foods, that's for the patients. And I should say, first of all, we had a challenge with the men. when we started data collection, it was during the World Cup football. So of course our men did not turn up. But what we did is that although we wanted focus groups, we had to resort to doing kind of individual interviews in order to get them. And some of these were done online. But the men, all participants were basically able to give, a fairly good definition. So most of them referred to plant-based foods such as fruits and vegetables, and a few were able to say food from all food groups and mentioned the proteins and the beans and the peas and so on. Next slide. So in terms of barriers to accessing food, the women were able to describe barriers. Of course, the men, most of whom did not prepare or purchase their own foods, were not able to tell me what the challenges were in accessing food. And we actually tried to put together a focus group with the persons who prepared foods or who were the care providers, food providers for these men, but it didn't happen. However, the women said that the main barriers to accessing food during the COVID-19 pandemic was the shortened time for shopping. Of course, we all remember the lockdowns, the increased cost of foods, especially produce from the markets. And they explained that a lot of the regular vendors did not turn up to the market, I guess because it wasn't worth their while coming for the shortened periods. And so they were mostly, it was a kind of, well, not a scarcity, less than would have normally been available. And so the prices went up. Many of them, though, especially the older women, were afraid. Their main reason for not being able to access their usual sources of food was fear of going out. Many of them had comorbidities. They were older women. And so, they kept getting the message about stay home, stay home. And so a lot of them did not go shopping. There was also the issue of cost to travel. The taxis, many of them use public transportation, and particularly the rural areas, they use taxis, who are now mandated to carry less passengers, and to accommodate that, to keep their income, they charge more for the trip. Next slide. Very few people got any assistance with food. It was very, very limited. And both rural and urban reported that the distribution of assistance was very unfair, very uneven. And there were some persons, particularly the urban group, that did receive occasional assistance from their employers. They said, especially in the early parts, they got food packages or vouchers or some such things. And the persons who had children in school, they said the Ministry of Education provided lunches in quotation mark, but many of them said it wasn't even worth the bus fare to go and pick up the lunches because what was being provided was not substantial. And so the cost of traveling to go get the lunch, it was not worth it. So sometimes they didn't go. Of course, those who belonged to churches or had a relationship with a church, they got food through churches. And of course, there was distribution. Most of the participants knew about distribution from political groups or political leadership. But of course, they pointed out that most of them didn't get because it was their party faithfuls who got. And they complained about, both in urban and rural, about the unfairness because people who didn't really need it got it, but elderly and very poor people didn't get the food. Okay, next slide. All right, what did they do to overcome the barriers to getting healthy foods? Some people, particularly the urban ones, who bought in wholesales, they bought in bulk. So they got together with other persons and bought in bulk. Many of the older people asked others to shop for them. People who were younger, they thought were less vulnerable or who had time. So they went to work and work finished early and they were able to get time to go shopping before the shops closed. And so a lot of people were asking others to purchase foods for them. Some of them reported purchasing and eating foods that could be stored longer. So a lot more peas and beans, fried peas and beans, and flour and rice and things that could be stored. Well, tinned things were mentioned. Persons who said that they were not able to get the usual vegetables and so on, they ate the things that would fill their belly because there was a shortage, and so they resorted to more, foods that they could have a lot of and not feel hungry very quickly. Some people, particularly the rural, they exchanged or shared produce from other people's gardens or farms, and they themselves who had, like they mentioned, breadfruit trees and so on, they shared with other friends. I was surprised that very, very few rural participants and of course, almost no urban participants do their own food. They complained about not having the space. And the ones who actually do their own foods had been doing so before COVID. So that was not one of the strategies to overcome the barriers. They gave good suggestions for dealing with the food crisis. Many of them said that part of the reason why the goods were so expensive, and they were expensive even before COVID, is because the farmers need subsidies in order to meet because the input in the farms, the fertilizers and the protective, what you spray to keep the thing, was too expensive. They thought that food prices should be regulated in a crisis, that in a crisis you don't allow people to, put up foods beyond a certain level. And they wanted the urban people appreciated the farmers markets, although some people complained that the prices there were very high, but they thought that that was a good way to get the food to them, the produce to them, these farmers markets, although they did complain about the prices. And of course, the main suggestion is to create a register of who are actually needy and use that register for prioritizing distribution because of the many complaints of uneven distribution of. Next slide. Okay, so I don't have another slide. I guess that's why the person was hesitating to move. I just want to report on the second part where we looked at the staff, the non-medical and medical staff. Everybody reported a very chaotic time. We, of course, presented the findings from the survey that was done with patients, and we asked them to give their responses about the findings. And all levels of staff they agreed with what was found. However, many groups thought that the sample that was taken when we looked at the educational level, that the educational level was higher than the patients that they were used to seeing. So they were a little surprised about the educational level. We had I don't remember the proportion, but those who had tertiary or post-secondary education was higher than what they know. All right, in terms of findings from the non-medical staff, they thought that the biggest challenge during COVID to keep in touch and get the medication to patients was the medical records. The medical records failed them, inaccurate addresses, phone numbers that no longer worked. The Manitoba Regional Hospital actually went out into the field to the communities, trying to send messages to people that they were going to be there with the medication, but of course, people didn't get the messages, so that was not as successful as it could be. The staff spoke about space, mostly non-medical staff. Space was a problem, registration, where to keep the patients while they're being registered. That was a challenge, and they mentioned using facilities outside of the hospital. And of course, the ability to communicate with the patients was a big barrier in terms of not only reaching them through telephone, but even, getting to let them know when your appointments have been canceled and so on. That was a big challenge. So we have to do something about our medical records in terms of being able to contact the patient. In terms of the medical staff, the biggest challenge they saw was the mobilization, not surprisingly, of the human resources. To quote a couple of administrators, they said that COVID just showed up a weakness. It showed up the weakness that was already there, so it just exacerbated the weakness in the level of staff. Um, they also pointed out that, in distributing staff, they had to bear in mind that some of the staff themselves had comorbidities, so they wanted to bear that in mind when redistributing. Of course, we all are aware that a lot of the staff that would work in the outpatient clinics were redistributed to the COVID wards. As a need, they saw the mental health of both the staff and the parents as a need that was not adequately met. They thought that the screening of the patients with symptoms worked very well, so they didn't think that there was too much exposure of the staff to people who had symptomatic COVID. The main suggestion was that the response was not as coordinated as it could be. So the main suggestion was that the response had to be more coordinated. So one person mentioned a regional coordinated response, so we know which health centers can accommodate patients from the outpatient section of the hospital, and that would have been useful not only to redirect patients, but also to redirect staff. So those were the main findings, and I hope that I have kept within my time. That's it from me.
Thanks very much, Dr. Bailey. So we are going to move into our coffee break time, but I don't think everybody has to go on a break, because we're also trying to use this time to answer some questions that people may have about any of the findings, or even just give some feedback. So I'm going to ask that all the presenters be available during the next few minutes. We want to use that time to respond to any questions that may have come up online from any of the persons, or if there are any comments that anyone wants to make at this time. This is a good opportunity. So I don't know if there are any questions online that I need to be made aware of, and if you have a specific question that you want directed to a person, this is your opportunity. You also have Dr. Bailey online to talk about her qualitative findings as well, which I think are quite interesting, and may explain a few of the things that we're seeing. A lot of her qualitative work was confined to Jamaica, just because of the time frame that we had to work with. So we may not have a good understanding of what was happening in Trinidad and Barbados. But if there are any questions or comments or reactions, this is a good time for you to make your voice heard. Okay. All right. Oh, Dr. Kong. Yes.
Thank you. I was just reflecting. I don't remember who it was, but when you had the looking at differences as it relates to keeping their appointments and so on, was there a difference among the countries as it relates to their usual appointments? So, for example, is in Barbados, is it more commonly that you have 3-month appointment versus Jamaica that you may have 6-month appointment? So I was wondering, since the period was March to May, I was wondering if like the sort of level of normal return for care. So
all right. So I guess so some aspects. Thanks, Dr. Kong. Good question. So some aspects were confined to that early period. So the dietary pattern, the intake that people had was really focused on the March to May. But when we asked about the appointments, we're looking at over a longer period of time. So the pandemic started in March. We actually did start our field work in about January, February, March the following year. So people would have had about a year of that experience at a time. So that should be enough time for people to have a good feeling for what was going on. I think the point that was made around the experience before the pandemic is important because we can't tell whether these are all attributable, but these would be, of course, concerns that people would have. Some of them are specific to COVID-19. So the questions that we had on canceling appointments because they were afraid or they were concerned that it was not safe to be at the hospital at the time of the pandemic. I know, like, for instance, University Hospital was one of the COVID designated sites, so a lot of patients would feel uncomfortable going into an institution where they were treating patients with COVID. Mandeville, I think, was also one of the COVID designated sites. So maybe some of those experiences. For Barbados, that there's one hospital, so you wouldn't have had much choice. And one major hospital. And for Trinidad, I guess, depending on the region, there would have been differences. All right, so there are two questions that came up online. One was from Dr. Kim Quimby, and her question was really what contributed to the reduction in food insecurity. Were they planting more, and whether these were different according to demographics. Let me see now who is, okay, it's only Kerry, so. So I'll respond a little to that because I don't think we didn't really see a big change in food insecurity. Even though the numbers look a little different. Barbados apparently seemed to be the one that where the proportion of persons who reported food insecurity appeared to go down after the pandemic. But I don't know if Dr. Quimby is online, if she can speak specifically to any specific measures that were being taken at that time. Because we also did notice a number of things that were unique to Barbados. So for instance, when a lot of places were seeing a reduction in vegetable intake and a higher reduction in vegetable intake, a higher reduction in fruit intake, Barbados actually seemed to have cushioned that period the best. And again, I was a little surprised because, you know, they don't have a very high agricultural output from the country. So I don't know if Dr. Quimby or anyone from Barbados can comment on what was happening in Barbados that might have helped to protect the food ecosystem a little bit more than what we saw in the other settings. Okay, you're not seeing anybody. Professor Anderson is on. He might be able to comment. He was from his experience, or maybe it's just a matter of the regulations that a little bit more structured in terms of like accessing, going on specific days. I don't know if any of those may have been things that would have contributed to maintaining a certain range or variety in the diet and eating at that time. Okay, so we don't have anybody from Barbados who can. Okay, there's a comment. Okay, please. Oh, the mic for microphone. Yes.
Okay, Carol Coy, Director General of Statin. It's two comments. The first one, your comments about the telephone questions. I really want to concur with that. We did a telephone survey during COVID just to look at the impact on employment. And no matter what Jamaicans tell you, and they'll say, even with the census, oh, we are, technology. They're not answering you. They rarely are answering you. Mm-hmm. And just a comment, I think Dr. Lee had mentioned already, during that period in Jamaica when we did that, the unemployment rate went up significantly. I mean, the numbers of persons who were unemployed. So I was sort of surprised that the food insecurity fell during that period. I would have thought we would have seen an increase.
Right. Okay. Kerry had wanted to respond. Okay. Yeah. So again, I would say that even though you saw little changes, I don't think they're meaningful in terms of a big difference. For the food insecurity during that during that period of time. But the employment, I think, would probably reflect a little bit more in terms of how we saw the patterning, because definitely for Jamaica is where we saw the biggest reductions in what we consider healthy foods during the pandemic compared to the other two settings. So even the things that would have buffered persons living in those other territories would be an important sort of difference to explain the changes we're seeing. And I do agree, I concur with your point about the telephone interview, because you know, there's somebody who helped to train us in the methods. They said, you know, the first thing that when people answer the phone and say, I'm calling, they say, how you get my number? So if you see, well, that's the first question you have to be prepared to answer. So if you can't answer that, you're gone. So that establishing rapport and the validity was very difficult. And then again, I don't know what method you use if you're doing random digit dialing for your interviews. I don't know how you selected, or just a general database. I know we were looking for specific persons and we're hoping to identify them through the hospital database. So we had to go with numbers that we had. We couldn't just go arbitrarily. The second question is, again, a question about food insecurity. It's from Shelley Ann Ford. And it's also about whether any reductions were due to social programs that were taking place during the pandemic. And I don't know if there's anybody who can speak to what was happening, or if there are any special initiatives that were. Any special I know we had some social programs, yes. People who are already in programs, the PATH, and so people did get some benefits. But I'm not sure if there's any specific ones that might have helped to buffer. And we're speaking primarily from Jamaica, so social programs, I don't know, Professor Simeon or any of the other speakers, if you can speak to any special initiatives that you had recognized in your setting that would be relevant to this discussion.
Can I speak from Barbados?
Okay, Barbados. Okay. Oh, okay, good.
Yeah. So I'm hesitant to name special programs because even though COVID was just a year or so ago, we've forgotten so much. First, there were programs to help those who were in need. Including they had NIS program, national insurance program for people to get funds to purchase their foods, and also there were other opportunities. So, for example, for persons getting their medications, etc., they had established a service to deliver medications to persons at home, etc. So that even though you had the impact of persons missing their appointments because hospital was unavailable, you still had some sort of continuity in terms of care. But this doesn't mean that they're getting the medications alone is not full clinical management of any condition, but at least it tried to buffer things a little bit as well. So there were opportunities for persons to get food from food banks and so on. And church, particularly through churches, I know that those programs happened quite a lot across the island and allowed individuals to get access to food and to services. Thanks.
Thanks, Simon. And Dr. Duncan has Dr. Prof. Simeon. Okay, go ahead, Prof.
Yes, just to point out that, yes, there were a number of programs throughout the pandemic, which of course lasted for more than 2 years. But during that index period, which is the first 3 months of the pandemic, they weren't able to really roll out any program to provide that type of support. Of course, the first 3 months was more panic and people not sure what was going on, and in which case, unemployment went up. So there were a number of social issues. But in terms of the programs that were rolled out by the Ministry of Social Development and Family Services, there were quite a few. Cash transfers, food, banks, etc., but not during the index phase of the program, of the study, where we actually collected data for the first 3 months of the pandemic.
Had a comment. So we have one comment here. Oh, Dr. Duncan.
No, just not that I'm qualified for that area, but I know in Jamaica certainly there's a reliance on civil society for social support as well. And of course, during the early phase of the pandemic, even those activities were curtailed. So I could see how there would be greater food insecurity because, even your faith-based organizations, their feeding programs, outreach work was curtailed. A lot of the church members were elderly.
Right.
And so, that would have affected significantly a lot of the social support programs.
All right. Thank you. Thanks very much for that comment. Okay. All right. So I think we're at the coffee break time. I know people can help themselves, and it's also an opportunity to stretch their legs, so we don't have to report that they're doing less than 150 minutes of physical activity in a week. We're going to take about a 10-minute break for those who are online, for people to do different things, and then we'll resume we want to resume at 11. There's going to be a change in the breakout rooms, so we're actually going to probably not have some of those, as many as we had anticipated. So we will come back to you and just kind of explain how many groups we'll have, and then we can assign people accordingly. Okay. All right. So I think people want to take a little stretch break, so I think this might be a good time. So let's do 10 minutes, and then we'll reconvene.